Welcome to the PTR Physiotherapy Rehab Podcast. My name is Warwick Schmidt, and in this podcast, we interview subject matter experts, authors, and elite athletes to help inform clinicians and patients and generate discussions around sports, rehab, health, and how to get people back to their best. We hope you can take away some content and use it in your practice. All right, welcome to the Physiotherapy Rehab Podcast, the PTR podcast, where we talk about all things musculoskeletal physiotherapy. Today, we're talking about an adjunct that we all use in our practice, manual therapy. And I'm very honored to have several guests, authors of the paper, A Modern Way to Teach and Practice Manual Therapy. That was published earlier this year. And we'll go through the paper, how it was produced, and the outcomes. So before we start, if we could do a brief introduction, this time all the way through. I promise we've started the recording properly, and then we'll work our way through to the project. So if we can start with Anna again. Thank you very much.
Hi, my name is Anna Maria Mazzieri. First of all, thank you very much for having us. My name is Anna Maria Mazzieri. I'm a soft tissue therapist, and you might wonder what a soft tissue therapist is. And it's a massage therapist trained at level 5, and we identify a little bit less with just massage per se, but more with approach to care. So in our scope of practice, we have assessment and rehabilitation, as well as manual therapy and massage. I was involved in the paper, and I'm so honored to have been involved, because I've been following Roger Kerry and his writings and musings for a while, especially his involvement with cause health. And because in my little world, in my little industry, I've been pushing for an evidence-informed approach to care, especially to hands-on care. And because in my industry, it's very, very difficult to disassociate it between the identity of being a massage therapist with very old narratives. I kept following Roger, and one day I think I don't remember, it was an Eventbrite, where he was starting presenting this idea of the paper, and let's say that I made myself a little bit known. I kept emailing him, and of how disappointed I was that soft tissue therapists were not involved in the process. And here we are. I'm here. As I'm Italian, I get into everything, really.
Excellent. Vas?
And I cannot tell you how honored I am, because those people here in the room are people I read the papers about. So being part of that is fabulous.
Great. Vas?
Hello, my name is Vasileios Georgopoulos. I am a physiotherapist by background. I have a professional and academic interest for manual therapy as an approach. And generally, I'm practicing in musculoskeletal pain, where in chronic pain, manual therapy does not really have applications, but I have maintained my interest on the approach anyway. I have been involved with manual therapy since 2013, when I came to the UK to do a master's, where the master's basically was delivered by Roger Kerry and other colleagues. And since then, I have maintained my relationship with Roger, and we have been engaged into discussions about manual therapy, initially as a student, and later on when I joined him in his classes, and we actually now deliver the advanced practice module, the MSK assessment and treatment module together. We have been discussing about manual therapy and how to best improve our clinical practice, but at the same time our teaching practice as well. And this has been like an ongoing process, as I said, since 2013.
Excellent. All right. Roger?
Hello, and thanks, Warwick. Thanks for sorting this out. It's great to be with everybody. Yeah, my name is Roger Kerry, and I'm a physiotherapist. At the moment, I run the undergraduate physiotherapy program at the University of Nottingham, and as Vas said, we deliver the postgraduate program together on the manual therapy side. And so I'm mainly coming from a teaching background, although my clinical background is in musculoskeletal and manual therapy. And through this project, it's been great to meet. I met Ken through this project via Steve Vogel and Anna, and we've got our Nottingham team and all the other authors. So yeah, it's been really interesting, as we'll find out.
Absolutely. And Ken?
Ken Young. I'm a chiropractor by background and currently a senior research fellow at the University of Central Lancashire. And in terms of and getting into the group, it was, a mutual acquaintance of Roger's and mine that introduced us. I'm not sure if it was Steve Vogel or it might have been somebody else. Anyway, it doesn't matter. When I heard what the project was about, that it was multidisciplinary, bringing all the manual therapies together, or many of the main manual therapies together, in an effort to devise a genuinely patient-focused approach to teaching and practicing manual therapy. I had to jump at it because that's been my approach for years now. And this has just been an absolutely great group to work with. And, I've got new colleagues and friends out of it. It's been a really spectacular collaboration.
Excellent. So look, I think we had an off-screen chat before we started recording about how thorough the process is, and kind of alluding to the fact that when someone sees the title, although it's catchy, they might assume that it was a little bit less formal and structured. But actually, the amount of work that's gone into this and how thorough you've all been, it's a real credit to yourself that we've got something here that's had several years of work into it. So it doesn't matter. I'm leaving it to the floor. From the paper, we've got stage 1, 2, and 3. If I'm correct, we've started in roughly 2018 when it formally kicked off. So how did you kick off stage 1, 2018? We had a literature synthesis and the idea of a change of practice.
So, I guess it makes sense for me to kick off here, and then Vaz and anybody else join in. This is very organic. I mean, this stage 1 was a long, drawn out process of doing what we do in education, which is continually review what we're teaching and the evidence behind it. And over a few years, it just evolved. We just began teaching manual therapy to undergraduates and postgraduates in line with the evidence, basically. And then there came a point, and Ed Lee, who's on the paper as well, he's one of our lecturers, and I can't quite remember, Vaz, me, Ed, between us over time, we developed this really simple triangle that just said, actually, there's loads of stuff we used to do in manual therapy, and you've probably been taught some of it that kind of doesn't make any sense anymore. All you need to do is be safe, make sure everybody's comfortable, and be very efficient in the way you do things. And we found that within that framework, you could do everything that manual therapy is supposed to do without the stuff that's not supported by the evidence. So you could retain the effectiveness of it by really simplifying it. And the big bonus to that was that it became very quick and efficient to teach as well. You didn't need to spend hours and hours and hours going through all sorts of things. So that was kind of the start, and then we just rolled on for years. And then sort of, I guess, we thought in Nottingham we should do something with this, and reached out across the professions to see what other people were thinking and doing, basically. So that was the start, really, in my mind. It was very, very sort of shop floor organic, and it just grew from there.
Excellent. From almost a need that the evidence was driving forward. And so when did the next stage develop? Then how did you develop into the following stage with the multidisciplinary stakeholders? In the paper, it outlines that stage 2.
At the risk of talking too much, I'll just say one more thing, and then I guess...
No, please, Roger. Yeah, I can jump in. Yeah, absolutely.
I was already doing some work with Steve Vogel, who's an osteopath, who's at what used to be called UCO, University College of Osteopathy, just changed institutes now for the brand new shiny Health Sciences University. But we were doing some work anyway. We did some teaching stuff together, not this, but other stuff. And then I think, we started talking, and this resonated with Steve in the osteopath school. And then I think at that point we reached out to the chiropractic profession, and found Ken.
Yes. All right. How did you get involved, Ken? What were the processes that you got involved in?
Yeah, well, that was about it. It was just, a couple of conversations, and we found an absolute synergy in our approach, and it's really interesting. I'd like to circle back to something you said at the very beginning, Warwick. You said the adjunct of manual therapy, and that's really interesting to hear from my perspective as a chiropractor. And since Steve isn't here to talk for the osteopaths, I'll talk for him.
I sort of put my foot in it there, but no.
No. So I'll try to represent osteopathy well. I actually spend quite a bit of time with osteopaths, and the development of chiropractic and osteopathy have been very parallel since the late 1800s when both of them were initiated. So in chiropractic and osteopathy, the general perspective is that manual therapy, and specifically spinal manipulation, are the default intervention, the default therapeutic intervention, and everything else is adjunct, right?
Got you. No, absolutely.
So that's that sort of tension between the two perspectives of chiropractic, osteopathy, and physiotherapy were part of what attracted me to this project, because what emerged out of it, what Roger had started, and Roger, by the way, you can't speak too much about this. This is you're the intellectual driving force behind this thing. So what Roger had developed was this balanced approach of some hands-on, some hands-off, and self-care and home care, active care, those sorts of things. And that balanced approach, I think, has a lot of evidence in the literature. And that's what we've demonstrated in this paper, because it was backed up by hundreds of references. In fact, we were told off by the reviewers for having too many references. But we just wanted to show that it was extremely robustly supported in the evidence, this balanced approach. And so any way that I could contribute to advancing that approach, what I thought would be useful to patients, because again, that's what the ultimate goal all the time is, right? I'm not here to serve chiropractic. I became a healthcare practitioner in order to serve the public, to help as much as I can in people feeling better and doing more, being able to do the things that they want to do in their lives. And so this approach was just absolutely a perfect fit.
Sure. Absolutely. So the next phase would be potentially talk about the traditional manual therapy centered around the clinician-centered assessment, pathoanatomical model, and the technique specificity. So briefly, Kerry, would you, in terms of each of those, what would the evidence say, summary of what the evidence is against that sort of model? What was it that we wanted to change about that model that we move on to?
So we sort of, from reviewing and analysing and thinking heavily about the evidence, as Ken said, this was a sort of big, deep pool of evidence we had to go. And these are the sort of three themes that really emerged from that we call the traditional manual therapy. As Anna was saying earlier, she summed it up in her introduction with sort of moving away from these narratives we have about manual therapy. And some of this is fueled by debates like the hands-on, hands-off debate, or the myths go around. I think they're redundant sort of conversations, really. It's not about that. All we need to do is look at the evidence and see what it does and piece things together. So, and it's really important to acknowledge all the other authors, of course, as well. But Dave Evans, who's also an osteopath, is really instrumental in sort of identifying how we might package this up and develop these sort of themes. And this idea of clinician-centered assessment is not supported by the evidence. And again, that simply means during the assessment or treatment techniques using our hands, trying to ascertain things like stiffness, for example, or the concept of resistance that we taught, and trying to turn that into something meaningful that might relate to a clinical outcome or something is just not supported by the evidence. We're just not very good at doing that sort of thing and making meaningful judgments on small movements that we may or may not feel. Whereas a sort of person-centered assessment might be reproduction of pain or symptoms or discomfort, or what does the movement mean for the person. So we just flipping that round, and that does have support by the evidence. I'll let other people talk about the pathoanatomical and technique specificity business. I don't know who wants to take any of those.
Could I jump in here?
Yeah,
absolutely.
So basically, I can add another layer to the whole discussion of how this all started, although I'm not going to go far back and then discuss about this. So as I said, we have been discussing this with Roger unofficially on the side of classes, sessions, whatever, basically. And we were always having this idea that, what we have been teaching or what I was taught back in 2013, some of the aspects of manual therapy were not really making sense in my head. They were overcomplicating things. So I'm kind of in the unique position of remembering how it was to be a student of manual therapy, and also how it is as a teacher of manual therapy to new students. And I have been discussing this with Roger essentially, and particularly things like, for example, convex and concave rule, and what is it that we say that we do, and whether that makes any sense, or whether that has any kind of any basis essentially on literature or evidence. And when we were discussing this and we're coming along with that, we were just realizing that actually this is not supported by anything. This is just, you could start going back in time, and then it was like entering a rabbit hole that you didn't know where to go, and you could never really find out where this all started.
The original references, yeah.
I mean, it's not that just the original references. I mean, what's the basis of this, like to claim that this is what needs to be done, and this is what, for example, you need to mobilize things in the convex or the concave, or you need to do a PA and not an AP. I mean, those things were overcomplicating a relatively simple technique or approach, which obviously requires high skill, but it's simple. It's basically mobilizing tissue, bones, joints, all of them together. And then as we were discussing this, I was asked by the MACP to do some kind of like a talk and discuss something of any particular topic. And then I just said to Roger, could we discuss this? And this is the point where Roger said, well, if we're going to do this, it's ideal to actually bring other professions in. And this is where Ken and Steve came in, and Anna, and kind of like it all started. And then after this whole thing became some kind of like a trend, then we said, like, wait, what we discuss unofficially, on the corridors between classes or lunch break needs to be more formal and needs to go to a paper, because we have good things here. And then yes, this is actually the specificity of it just doesn't appear to be relevant anymore, I think. And as a student and as a teacher, I was saying, like, this just wastes time, resources, but most importantly, like, energy. So, and we still see it today, like, students coming from all across the world, and they still ask us, well, we have been taught about the convex and concave rule. And then me and Roger kind of like dismiss that and try to, not dismiss it, but, we try to deconstruct that and try to kind of make the students understand that this kind of thinking is outdated and we need to move forward. And this whole thing is a dynamic approach and requires a lot of back and forth with different people in order to, to make sense of it and produce something that has value.
Sure.
The paper was criticized because it's called modern way to teach and to practice and teach manual therapy. So on Twitter was quite highly criticized. So, oh, this is not modern. People should have been practicing so for decades. But actually, this is the first paper where everything has been brought together in such a structured, precise, elegantly written, and very unthreatening, in which everything is being put together. And the literate, as an educator, I just now have, I just say, look at the lit review here. And you cannot anymore say, oh, well, maybe this research said, because the literary review is so comprehensive and really shows where it's not one or two papers, not one or two studies. This is a body of evidence which we must, as manual therapists, now change our way we practice and teach in order to fulfill, in order to actually do justice to our clients. The pathonatomical view of the person, the paternalistic and pathonatomical view of the person, it hasn't got a space in most of MSK care, and we must move on for it. And more we go into the specificity, and sometimes it's quite, what I like about the paper also, because he actually gives explanations. Because he sees it as an educator, I see that some of the students get the idea of the complexity of the pain really well. But then when they have to go into clinical practice, when they close the room and they're inside the clinic, they still focus on that particular orthopedic test for the shoulder, on that particular exercise for the muscle, on that particular stretch, on that particular rehab. And so, while this paper literally gives justice to the complexity of actually practicing, and he removes the specificity as well. And then I pick on what Ken said about what you introduced at the beginning, Warwick, by saying it's an adjunct. That's exactly what manual therapy is, the context where the true interaction, the true meaningful care takes place, which is comfort, which is reassurance, which is identifying red flags, and instigating self control over the pain and so on. So
absolutely. Now, just for the listeners who may have not read the paper in that much detail, we've got a sort of 3 practical elements: safety, comfort, and efficiency, and then some sort of conceptual themes, which we'll talk about after. So, Kerry, could we expand a little bit on how this model views safety and how clinicians listening to this might apply that element of the practical component?
So, I mean, all of these things have got different layers to them, and we try and sort of sketch that out in the paper. So safety can mean anything from a very basic safety. Are the brakes on the plinth, and are you not too close to the edge of the plinth and all that? But there's the idea of, then a more detailed level of safety. So again, if you think about this directing the application of assessment or techniques, so maybe, and this is a nice way to think about it, because again, part of the criticism of this is, if you take away all that stuff we're saying you should take away, the specificity, the pathoanatomical reasoning, the clinician-centered thing, then one criticism people have said, you're not going to be safe if you do that, because you need to know all that stuff to ensure your safety. But you can just approach the safety from a really basic humanistic way and say things like, so if you take the neck, for example, which is the an obvious thing, and you don't need all the old elements of traditional manual therapy to be safe in mobilizing or manipulating the neck. You just need to know what the evidence says about it. You need to know some risk factors. You need to have done whatever evidence-based sort of screening there is, and you can be absolutely safe. You don't need to do anything special tests or whatever. and the skill can be driven by the safety as well, which is the other criticism. So are you losing the skillfulness of manual therapy if you take away all that traditional stuff? But you're not at all, because the safety element drives the skill. If we're thinking about just wanting to do the, no harm to our patients, that's going to dictate what we do with our hands and the amount of pressure we put on, or the progression of techniques. So just something really simple, like a common sense word like safety, can do a lot of work in terms of development of your skill and application of techniques.
Sure. I mean, so that in terms of application of my background, it is sports therapy. So I've done a lot of massage and I use it a lot. So it also tend to drift towards what I think a lot of physios do, which is when you're doing massage, you find the tight spot and then you work on that bit. But the question I might have from my point of view would be, if you have a general way of applying, say, a neck mobilization, or if you're aiming for that, is the case where obviously we're looking at red flags, we remove any contraindications, and when treatment starts, are we then using palpation to find a specific level, and then the non-specific nature of this new concept is we just go to where the patient can cope, or are we then using a much broader way of applying the treatment? Does that make sense? Instead of finding a C5, 6 facet and we go across and down and we do a PA, how would this model look compared to someone doing that? What would it look like?
So I mean, I guess the others will jump in on this as well, but very quickly from me, it's, there's no evidence to suggest that segmental specific or even regional specific techniques may have a particular effect. You get the same neurophysiological effect regardless of a particular segment. And because we're not able to reliably understand what is comparatively stiff or tight or restricted, that's it's one of these sort of ancient traditional things that have guided practice that we realize kind of we don't need. Ties in very much with Ollie Thompson's anatomical possibilism theory. We can make things up about the anatomy and feelings that kind of don't matter. We can still get good clinical outcomes regardless of that lack of specificity in terms of segments or whatever, but we can still be very specific in our application in terms of the safety and comfort and effectiveness. So I'm guessing other people might want to say something about that.
Yeah. Oh, sorry.
Well, I'll jump in with a chiropractic perspective, and that is that what I found really interesting as I was going through my training, and I was trained in the old model of technique specificity and finding the exact segment and moving it in an exact way, that sort of thing. And what the question that popped into my head was, well, wait a minute, not every chiropractor, osteopath, has always diagnosed exactly the right segment and moved it in exactly the right way throughout history, right? Millions and millions of spinal manipulations around the world. So why isn't, if disease or conditions are being fixed by this spinal manipulation, why aren't they being induced by the spinal manipulation? And now we've got the evidence for the answer is that it doesn't really matter if you move it around in the area roughly, maybe spinal region, you get very similar effects.
Sure.
And that's really useful, and yet it goes against tradition. And I think everybody understands in this modern world how much people love change. Everybody loves change and throwing away traditions, and so there's a lot of kickback on that. But you have to go where the evidence is, and you have to do what's right for the patients. So we're in a new space, and that's okay. It doesn't take away from what we do in our professions.
Sure.
It's just a new way of doing it.
And maybe also
one final thing. Just sorry, Anna Maria. Just if you look at it's a little bit tricky with the paper because there's an additional file that you have to download separately, and it's 2 case examples of how this system works. So anybody listening to the podcast who might have the paper, don't neglect to download that additional file, because it really lays it out in great detail about how you approach the patient with safety and comfort in mind, and can still get the same results without resorting to the traditional methods.
Sure.
The lack of specificity, the lack of evidence, the specificity is not the segment that we're going to move, because that's not our outcome anyway. It's not the outcome we want, but we can be specific on where we touch and how we touch, because that makes the client feel comfortable. In massage therapy or manual therapy, if I go and work into an area that feels that sometimes the client says, oh yes, this is exactly where I feel the pain. That's very validating for the clients. And what I'm going, and I'm explaining that, I'm not going to go in touch because with my touch, I change anything or I mobilize. It's because I'm creating the neurophysiological response, and because actually the client feels validated. So that's where the specificity should be, not into the pathanatomical, into the anatomy, into the way we touch and how we touch. That is the true specificity and the true skill of manual therapy.
Yeah, absolutely. I mean, these questions are coming from someone who also trained in the traditional way, you know, your PAs, your PIVMs and all that stuff. So it is also, I like, and I think a lot of physios are also on board. We've had a lot of the evidence build up over the years. We like that there's no specificity, but I think there's also a bit of a jump between talking about it in this forum, sort of in the corridors, and then having a patient who's in a lot of pain, and actually how many decades of experience have you gone and go, okay, well, there's a PA, I'm going to do that. That's the trying to transition from that model to this model is probably going to take clinicians a bit of time and a bit of practice. And that's my gut instinct as well, even though I'm fully behind the evidence, is that I would use my gut instinct is to just go and do it right. So it's L4-5 fasted PA, 3 times 30, you know, grade 4. I mean, maybe not the grades, but it's that level of specificity that it's still taking a bit of time, even though I think it makes perfect sense. I think the difference for me from maybe a lot of physios will be, as a sports therapist and a physio, I'm a bit more biased towards exercise, hence why the adjunct was mentioned. But I have gone through the whole process of burning my thumbs out, doing lots of manual therapy. And I think for me, the difference is doing sports massage and then manual, compartmentalizing it into a mobilization or an adjustment. So that's how in my head I would split it. I know that they come under the same thing, but sports massage is where we find a horrible spot. We sit on it, and that's the patient's pain. Whereas, you know, somebody who's a bit more rigid, wants to go and use joints as a mobilization, and that might take some people some time.
This is not maybe the right forum to discuss this, but I would disagree about that concept of what sports massage is, what manual therapy is. Yes,
no, sorry, the sports massage
all under the umbrella
I know it's
manual therapy. One is
a lot more specific.
Sustained touch, and one is manual therapy for joint. But even what I wanted to say, though, that is, you can still do your mobilizations and manipulations. Is the concept behind it that makes a big difference.
Absolutely. Yeah, and I think that's it. As I said, just not to reiterate, but that
I would like to add something
of level.
Yeah, I would like to add something to Anna's last comment. So the underlying thing here, and you mentioned like a couple of times, is pain. And all these people seek treatment because of the pain primarily. Okay, predominantly, I would say, some for function, but the underlying thing is pain here. And I mean, our understanding about pain neurophysiologically has improved and like immensely over the last 10-15 years. So the previous model of specificity, when we know that actually the pain lies in context, does not really fit well, because obviously when you want to promote physical health and when you want to promote pain relief, you can't really contextualize, oh, I'm moving now, you're C5 over or you're C6, and this is what's happening. You can't do that because the brain does not really, catch up with that, because you have to contextualize the movement. So by mobilizing the neck in a way that doesn't add specificity, or do not promote that specificity, and you mobilize the neck, then you kind of promote more feedback into the brain that actually could improve the pain eventually.
Sure.
And I think this is the thing that sometimes happens, is we have focused so much over the past decades on actually promoting this kind of movement that we forgot, or we kind of never really realized how, the biopsychosocial model of pain and pain improvement, how it's actually, dictates to change course. You can't really just go down that hole anymore, because you know that you have to make things much more holistic, and you have to take the context into account.
Yeah.
And you can do that by
Absolutely.
just, as you said, exercise. Yes, fine. But manual therapy, from what we know from the evidence, is not supposed to be the treatment on its own. It's just a window of opportunity to promote other things, to contextualize the pain relief. It's not really, okay, come here, have a thrust, go home, fine, you're perfect. We know that this is not evidence-based anymore. So we have to move on.
Sure, absolutely. In terms of the three components, we've mentioned quite a lot of this crossover anyway, but comfort and efficiency, we've covered quite a bit of that the skill set of efficiency will come from practice. If you had somebody who was a staunch MACP, driven by pure kind of guidelines and teaching, how would you advise someone who's in that way to then, how could they apply what we're talking about now? If you had somebody who isn't necessarily as buying into it, how would they apply these concepts?
Vaz is a staunch MACP kind of guy.
So somebody who's still yet to get, absolutely, who's still yet to kind of get their head around a less specific treatment and in that model and level based. How would they develop their skills into this way?
So from a teaching point of view, I mean, if they have learned manual therapy in any way, then I would say, you have learned to do things. I don't think that actually the way you learn necessarily made you good at it. It's probably your own passion, your own drive, and your own, basically charisma or, skillfulness that actually allowed you to do that. Sure. I would say I would use, evidence and say, all that is fine. You learn them. Okay. But now use your mind to kind of think, do they really have any substance? Do they really, are they evidence-based? Are they go well with logic? And if the answer to that is no, then obviously you just carry on doing your manual therapy things. Just try to think about what you want the outcome to be, and think about the context and think about the patient. And all the other things is just fluff that you can actually very easily trim out. If somebody has not had the training and wish to have the training, I would say good, go for it. But at the same time, you need to actually understand that what you had in mind, perhaps as as somebody who was introduced, that you're going to find where actually something is stuck and you're going to unstuck it. It's not really this. We're not going to be teaching that. What we're going to be teaching, we're going to give you the skills to actually be efficient and, again, safe, and to be able to understand why you're doing what you're doing. This level is not really necessary, and it's not going to add you anything in your career. It doesn't add anything to your career at all. It doesn't make the difference between pain relief and no improvement. It doesn't. This is not what makes the difference.
No. And in that context, so the skills you're talking about would be palpation, hand placement, communication skills close to the patient. So you then allowed to. Yeah.
Absolutely. I mean, without hands-on techniques, there is no manual therapy. And actually, we do know that the hands-on is an essential component, and it promotes all this kind of like rapport with the patient and this kind of like calmness. And it could be the difference in winning somebody over. So yes, hands-on has to be there, but you don't have to stick your fingers into like the C5, C4 left facet joint to actually make this count.
No, that's it. I think that's it. It's just nailing that down. I think Yeah, there's definitely obviously exposure to the manual therapy and all the benefits. You then have the time to educate patients when they're on the plinth, and maybe have them a bit more vulnerable for that, and they can then learn from those discussions. Ken, in terms of their skills and hand placement, it's probably a little bit more for chiros. Would you say that it's also changing for yourselves on how the skills are taught in terms of being specific and, old school, the kind of way of hearing that I've adjusted L3. I know that's nowhere near what the evidence says, and that's obviously what we've been working through. But how is it that you maybe new people are being taught with that, using this method?
It definitely has been changing over the past 20 or 25 years as the evidence has been emerging.
Mm-hmm.
And yet there is a strong reactionary force. It's definitely a small minority, but I think in both chiropractic and osteopathy, there is this reactionary force that is emotionally tied to the traditions and the founding principles of each profession.
Mm-hmm.
And that's very challenging. And here in the UK, the way that chiropractors and osteopaths practice is generally in a solo type practice, or possibly with a few like-minded practitioners.
Yep.
So the traditions can carry on because of there's not the clinical governance structure that physiotherapists might have, that medical doctors have. And so that structural element is a challenge. The emotional attachment is a challenge.
Mm.
And a sort of defensive fear of losing identity is something that I've heard quite a bit as well. Well, what will we be as chiropractors if spinal manipulation isn't our thing? We own that, right?
Yeah.
Well, okay, that's great, but how does that get the patient better, right? That tight adherence to the traditional model, how does that help the patient? And then we move into the realm. I mean, this is a very huge question you've asked here.
I know we could be here for a while.
Yeah, of confirmation bias, because generally patients love their chiropractors, they love their osteopaths, and as practices evolve over time, the types of patients for that particular practitioner's style self-filter into that practice, and so of course they appreciate the treatment. And so the chiropractor feels good about what they've done every day, and generally rightly so. But it's not the whole picture. It's what we like to do in science, and I am a researcher now, is sort out the active ingredients from the inert ingredients, right? So if we're claiming that spinal manipulation is the active ingredient that causes the change in reduction of pain or ability to pick up your grandson or whatever it is that you want to do in your life, then there needs to be evidence for that, and that needs to be gained through a scientific method. And I just led a large systematic review examining the evidence on anatomical effects of spinal manipulation. And the many of the traditional anatomical reasoning was not supported. There's not evidence for realigning the spine. There's not evidence for putting vertebrae back in place. In fact, the evidence that exists is negative about that. Those sorts of things. There is a little bit of evidence about reducing spinal stiffness and gapping facets in a temporary way. But that's all we were able to find in terms of anatomical changes that occur with spinal manipulation. So straight,
yeah.
But the
Big
question is very big, and it encompasses all these different ideas.
I spoke to a chiro about this topic, and she explained it that her more modern chiro, she does rehab as well, and she does uses a lot of evidence. And she actually, I thought she was going to say, well, we actually do. Shows how ignorant I am, and then she was going to say, well, we do specific levels and manip. But her way of wording it was that she wants a good adjustment. She's going to aim for L3 or a rough area where she thinks the tightness is. But if she gets the adjustment, she doesn't really mind whether it's up the whole spine or whether it's one level. She wants the kind of goal is to make sure there's the treatment relief at some level and in the right direction, but not at a specific level. And therefore, that's the outcome that kind of they're looking for, and therefore not relying on heavily on a one level. So I guess it's sort of
okay. Well, that's progress, right?
Yeah. I know, and I was surprised. I thought she was gonna, No, because as I said, we've all going through, and as you can tell, I mean, hopefully I haven't offended anyone with these questions. It's also because I've read the paper, but also it's interesting talking to you in this forum. I can feel myself wanting to just push the same questions, not that I'm trying to push against everyone. I firmly believe that this is, it has to be. We have so much evidence, and we've been all doing it, really, most physios, but you can feel, I feel that I'm going back to all these questions, and so it's going to take a bit of time for myself even to then start applying these in practice and not relying at as Vas says, just the specific level and using the skills through that. So I guess we could move on. I've got a few more, really. But the other thing that was asking about was the contextual scenarios. I guess that's also quite important. The way that people dress and how professional the clinic is. There's a brief section on that. I think that's fairly understandable. People get their heads around it. But yeah, I guess the outcome is that we are then trying to move towards this new model. And do you have any kind of final thoughts on how people can start really using the paper a bit better? What can they take away from it that you want, kind of the 2-3 bullet points that you'd want clinicians to look at and go, cool, I'm going to try and do that in practice?
I think you mentioned one of them there were with the contextual effects. So it's a good example of, so if there's a take-home message from me, it would be about, we've got this thing called manual therapy, and it takes different forms, and it has done throughout the ages, and we're in this place now, and we know, there's demonstrations of it being clinically and cost effective in the right sort of populations at the right time. And all that, but the things to focus on have changed. So rather than focus on, is this the right direction that facilitates this movement or whatever, that was something we may have focused on. We can still use the power of manual therapy, but we can focus on something like the contextual effects or the communication, and they're part of the package of this modern manual therapy. The person-centeredness and the ultimate, the goal. It's interesting when you was talking about your chiropractic story, and she used a narrative like, this is the outcome I want. It's the adjustment. The outcome should be further than that. The outcome should be, I want to get this patient back to work because they're not contributing to society. And here's a little piece of the jigsaw here. And if I get the context right, if I get the communication right, I get the safety right, blah, 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 we can then get them to engage in better movement, exercise or whatever. So it's just repurposing the role and the elements of it.
Absolutely. No problem. Anyone else to the floor?
Yes. Sorry,
okay,
you
go ahead, Anna.
No, you go, Ken.
Okay.
Yes, this.
Okay. Okay, Anna.
This is yes. To me, the biggest message is, ultimately, you do not provide manual therapy. As therapists, we provide client care, person care.
Mhm.
We provide care for MSK care. So our outcomes should not be, or our intervention, in fact, it should not be an intervention, it should be an encounter. So we need to rephrase the way we see ourselves. And I'm very passionate about what Ken said about the fact that often as manual therapy, chiropractor and massage therapists, very much, we identify so much with what we provide that we struggle when that is put under question. But it's actually, it should not be about us. It should be about that person. What is the outcomes? And this is what we provide. We should provide care, not manual therapy. So that's what we need. And manual therapy is part of it. I use manual therapy as part of client care.
Sure.
When it's needed, or when I think, through shared decision making could be effective.
Great. Ken?
Well, we're definitely developing a consensus here, because my first line thought was also focus outside yourself. It's not about the clinician. It's about the person sitting in front of you that needs help in some way. And that your toolbox is full of tools. It's not, you've got one main tool and the rest are, sometimes I'll use these, maybe. It's a big toolbox, and all the tools are equally good. Certain tools are better depending on who's sitting in front of you, right?
Mm-hmm.
Not depending on where you think your skills lie, or how your training taught you to treat somebody. It's about what the person needs from you. Those are the tools you have to then select and use.
That's where the specificity comes into place, isn't it, Ken? Specific not to the segment, but to the person needs, like a tutor or a lecturer. We need to understand our students, the way they learn, and the same is with our clients. That's the real specificity. That's where our role is, understanding deeply who they are, so that then we can collect from evidence how they respond best.
Absolutely. Vaz, do you have any last comments? We're running a little bit of time.
So basically, I second everything what everyone said about this. My key message would be that people need to embrace manual therapy. I think over the last decade, there has been I mean, it didn't happen on purpose, but kind of the manual therapy was demonized at some point, or the hands-on techniques were demonized at some point. Oh, it doesn't work, or it doesn't do things and doesn't do that. And part of that is this kind of obsession with specificity, because obviously when you try to break things down or to make them that narrow, you actually kind of like you miss the forest, and you look at the tree. And I would say that use your best training, use your skills to just promote movement. Use your manual therapy to promote movement, and don't think about where this is happening, and make sure that you communicate what you want to do. Make sure that you know what your patient needs, and then be safe, and everything else will happen. And actually, from a clinical point of view, I mean, the patients do not like this kind of like hands-off approach that has been adopted over the last decade. And I'm sure that eventually we will come back to this. We will come back down to hands-on stuff, because the patient needs, because without the hands-on, it's it's just nothing. It's just a sterile treatment that doesn't lead to anything.
It does.
Fast,
definitely feeds into our identity as physios. That's kind of, not that we give them what we want, but if they're coming for it and that's what we're skilled in training for, then I can understand there that if there's no evidence for any of these specificities, and clinicians get scared away from it and they go hands off, and we've all met hands off clinicians, and I think people recover so much quicker. They get a little bit better as when you get your hands on. So having that at least addressed and people leaning back into it might be a really nice way that the people will help. Yeah.
Within an active inference framework, touch is a prior that our brain recognizes. So people that already come through our doors are people that they're
Mm.
self-selecting.
Yeah.
Just the thought of being touched, they confirm they confirm their predictions, and you already know that they're going to respond, and that's okay, because it's not about me wanting or not wanting to touch them or giving them what they want. I am finding something, a strategy that I know they respond with.
Absolutely.
And then, I introduce maybe more challenging, there is, there could be also motivating. I mean, the research is not very strong on that, but, we need to start looking at it under a different framework. And I think predictive process and active inference framework, I think is a really good framework to be looking at.
No. Well, that's excellent. Thank you so much for your time. We'll finish there. We've got a few minutes left. I hope you all have a good weekend, and definitely for the up and coming seminar and MSCP event. I hope it goes really well.
Thank you.
Thanks
very much, Warren.
Thank you very much.
Having us on.
All the best. Thanks,